why we were waiting, but here we are. Thanks for coming. It's been a while since we've had one of these presentations, and this is completely new because I am not a physician. You don't want me to be your physician. I'm really thrilled that you could join us. Know that this is the first of 3 parts, all on cardiac care. I'm Andrew Wilk, by the way, if I didn't say that. I look like that guy. So before we begin this important presentation, I want to share a personal anecdote about the importance of being in the right place at the right time. And I'll start by saying you are in the right place at the right time. So sometime in the mid-1980s, I was conducting, because I'm a show business guy, if you don't know that, I was conducting the orchestra for a benefit production of the musical Kismet, based on the music of Alexander Borden. The performance was a fundraiser for Overlook Hospital in Summit, New Jersey. After scene 1, the lights go down, and then I conduct the requisite scene change music. The lights don't come back up. I say, well, they must have some technical problem backstage. I play the music again. No lights. The audience is starting to get antsy. By the way, because this was a benefit, the audience was probably 50% doctors and their wives. A lot of doctors, maybe 500 doctors. So all of a sudden, the stage manager makes an appearance. He comes down to the lip of the stage, looks down at me in the orchestra pit, terrified, and he stands up and says to the audience, "Is there a doctor in the house?" So now with all these physicians, there's tittering, there's laughter, and one brave doctor stands up and says, "What kind?" And so the stage manager says, "Heart, I think, heart." So 5 cardiologists stood up and rushed to the stage. So indeed, our leading man was having a heart attack. I'm happy to report that he fully recovered and missed the rest of the run of Kismet. His understudy went on, and it was absolutely terrible. But somehow we got through this, and we made a lot of money, as we always did for the hospital. This was a once-a-year thing. So this is all to say that he was in the right place at the right time, and so were you. But don't let anything happen. So we've got 3 wonderful doctors with us here tonight. We have the current doctors here. We have Bob Altbaum, who many of you have been his patients. We've got Ari Pollack, cardiologist, and Mitch Dreisman, who I saw about 7 hours ago, my cardiologist. So I'm going to introduce Bob, and he will introduce the other 2 doctors. Bob is going to host this series for us. He recently retired from his practice in internal medicine associates of Westport. He's the attending physician, or was the attending physician at Norwalk Hospital, where he currently teaches. Bob received his medical degree from Harvard University and completed his training at Mass General and Yale New Haven. When not teaching residents, spending time with his family, or playing various racket sports, Bob likes to rock out with his almost all-physician rock band. I think one of the most fun things is C. Everett Koop, our former Attorney General, said they were the best multi-specialty rock band in Fairfield County. They are indeed great, and we're blessed to have them. We're blessed to have all 3 of these doctors. So I'm going to turn it over to Bob and get off the stage, because I don't know anything about this. So thanks for coming, and Bob.
Thank you, Andrew. Really appreciate it. Thank you all for coming. I see a lot of very familiar faces, which is very gratifying, and welcome to the first in our series of cardiovascular lectures, conceived of by Andy Wilk and supported by the Westport Library. As Andrew said, my name is Bob Altbaum, and I'm really pleased to be the moderator tonight. Tonight we're going to talk about coronary artery disease. You may or may not know it, but cardiac disease is definitely the #1 killer in the United States. It's estimated that about 25 million Americans have coronary artery disease, which is basically a progressive blockage of the arteries that feed the heart oxygen and nutrition. And from that 25 million, every year, 1 million people have a heart attack, and 500,000 people die annually. That's like a mini pandemic every year. And tonight, I'm proud to present 2 speakers who are going to really help us fight back against this disease. Our goal tonight, as in all upcoming lectures, is to obviously educate the public, teach you about the symptoms and the tests that are involved in a particular disease, and also to review what's really remarkable strides in the treatment of these diseases so that we can all live longer and healthier lives. And that's happening as we speak. I will briefly discuss the development of coronary disease. Dr. Ari Pollack will talk about cholesterol, its contribution, how to treat it, and then talk about some of the symptoms of coronary artery disease and the tests and medical treatments. And finally, Dr. Dreisman will talk about the more kind of elaborate interventional catheter treatments that we have to treat people. Dr. Pollack, I'm going to read this because Dr. Pollack received his medical degree from New York University, fulfilled 3 years of residency at New York Presbyterian Hospital Columbia Medical Center, and completed his cardiology training at Mount Sinai Hospital Division of Cardiology. And currently, he is an attending physician and director of nuclear cardiology at Cardiac Associates in Fairfield. Dr. Dreisman received his medical degree from Brown University, completed 3 years of residency at Tufts, New England, and finished his cardiology training also at Mount Sinai Medical Center. He is currently the head of cardiac catheterization and angioplasty at Cardiac Specialists in Fairfield. I think we're really very fortunate to have such gifted cardiologists to speak tonight. But let me start off first with a little bit of an overview about coronary artery disease. The heart is an amazing organ. I think we all know that. It's a muscle. It contracts. Blood inside the chambers are then pumped to the rest of the body. And in order to do this, just like any other organ, it needs blood. It needs oxygen. It needs nutrients. That blood is not supplied by the blood that's inside the chamber that it's pumping. It's supplied by arteries that go around the muscle and feed the artery. And this is kind of a picture of what that looks like. As you can see, we take the pointer. There are 3 predominant arteries. This is the aorta, the main artery of the body, and this is the right coronary artery. This is called the left anterior descending, and this is the left circumflex. These 3 arteries basically provide all the oxygen and nourishment to the heart muscle. They have little tributaries. They get smaller and smaller as they dive into the muscle, but that's where we get our oxygen supply. And basically, what coronary artery disease is when the opening of these vessels become narrowed and the oxygen and nourishment begins to be basically blocked off. We call that coronary artery disease. Now, there are many causes, potential causes of coronary artery disease, but the most common I'm sure you've heard of is a term called atherosclerosis. And that's a progressive disease that basically occurs as cholesterol builds up in the lining of the artery. So here would be a normal artery. This is the beginning of cholesterol buildup, and you can see it's beginning to narrow the opening. We call that the lumen. It begins to get larger and larger over time, because basically building up as a mound of cholesterol and inflammatory cells. So the eventual development is what we call a plaque. And this plaque is capable of popping. It ruptures like a little volcano. And the body mistakenly, when you cut yourself, the body forms a clot and tries to heal it. But when this forms a clot on top of the cholesterol, there's nowhere to go for that clot. It just blocks off the entire artery. So this entire artery now becomes blocked by clot, and blood can't get through. And basically, this is the progression of atherosclerosis from really a basically normal heart to a heart attack. This is kind of a little pictorial. There'll be some more videos later, but this basically shows how the blood vessels have to struggle to get through the lumen, get through the opening to the rest of the heart. This is a cross-section, and I think this is actually very descriptive. If we took a tube, when you take a tube, you can see the long way. This is a cut through the artery, and again, here's a healthy vessel. That's the opening. Blood vessels are happy. They're getting through, no problem. In the beginning, we get a little bit of fat, but you can see that enough oxygen is going to get through. You have some coronary artery disease, but you don't have any symptoms. The spectrum of coronary artery disease is very wide. But as it progresses, here the plaque is growing, and the lumen is getting narrow. Now, this heart is getting enough oxygen when it's at rest. So you don't have any pain, you don't have any problems. You're sitting still, you're not using much oxygen at all. And then you go out and you run a block, you shovel snow, you do something very physical, the oxygen requirements go up tremendously. The problem is this blockage prevents the oxygen from augmenting. The blood supply cannot go up. And the heart basically begins to cry out for oxygen, and that cry is really perceived as pain, and we call that exertional angina. If you're exerting yourself and you can't get enough oxygen, you start to have pain in the center of your chest, and that is what angina is. When you stop exercising, the amount of oxygen required goes down, the pain may go away. So it happens with exertion. That's the next level or symptom. And finally, that plaque pops, a clot occurs, and you can't see that's supposed to be a clot. Nothing is getting through this artery. No blood can get through that artery. Well, if there's no blood can get through that artery, there's no blood supply coming even at rest. No matter how little the heart is using, it's not getting any. And what happens is heart muscle dies. And we call that a myocardial infarction, which means myocardium is heart muscle, infarction is cell death. And that's basically what a heart attack is. We call it heart attack. It sounds maybe more dramatic, I don't know, but the technical term is myocardial infarction. And as I said, 1 million of these are occurring every year. So what contributes to the heart attack or the buildup of atherosclerosis? There are many causes. This is just a list of some, but the most common, which I'm sure you've heard of, we call them cardiac risk factors. And one is hypertension, which is why we like to treat high blood pressure. One is cholesterol. One is diabetes, smoking. The list goes through important ones that sometimes we don't really measure, but we ask patients family history. If you have a young father or mother who had coronary disease at a very early age, that would be premature heart disease, and that puts you at risk. We can intervene on many of these, and one of the very important contributors, one of the really key ones, is cholesterol, which is what Dr. Pollack will give us his perspective on. He's going to talk about how it affects the arteries and how we can prevent it from causing life-threatening coronary disease. And then he'll discuss some of the symptoms and tests that are associated with coronary artery disease. So I give you Dr. Pollack.
Thank you for having me. I think this is such a wonderful opportunity to spread important medical information and education. And I think we're so lucky to live in a town with such wonderful amenities that offer services like this. So thank you for having me again. Happy to be a part of it. And I just wanted to say it's an honor to be on stage with two pillars of the medical community for such a long period of time. I mean, the amount of wisdom here is it's pretty incredible. And Mitch, I probably wouldn't be here if it wasn't for you. So thank you for recruiting me here. And I was actually telling a patient earlier today that when I moved here in 2016, it was daunting trying to build a practice, but I knew I had made it, that I was doing something right when Bob Altbaum sent me a first referral. So, so we're here to talk about coronary artery disease and cholesterol, and I know there's sounds like there's a lot of doom and gloom, but the good news is we're really good at treating this medically and really good at intervening before there's a problem, so rest assured. As Bob pointed out, heart disease is a big problem in this country, 600,000 deaths per year. Over 1 million people in the United States suffer a heart attack per year, and it is not gender specific. Both men and women are susceptible to the development of heart disease. As a guess, what percentage of Americans do you guys think is doing everything right? Exercising, not smoking, eating well? Any sense? 3%, yeah. So it's, so we have a lot of responsibility to help people, and the good news is, like I said, we can do it, and we're very good at it. One of the things that I wanted to point out on my atherosclerosis timeline is that coronary disease begins early in life. As Bob had eloquently mentioned, it starts with lipid accumulation, cholesterol depositing in the blood vessel walls. And if you could see on my slide, this starts in your 30s. And we have autopsy reports from the Vietnam War that demonstrated coronary artery disease in young men. And we have wonderful imaging tools that actually can demonstrate the presence or absence of coronary artery disease even in young people. And the key is to intervene early. We want to get to the patient when it's early, and we can change the natural history of what might happen to that person well before we start to see in the 4th, 5th, 6th, 7th decade of life where the calcium has deposited extensively, where the patient is experiencing deprivation of blood flow, and of course before there's a plaque rupture, which is the mechanism by which heart attack happens. On the left is a picture or histologic picture of a perfect artery. On the right is an example of what happens in the setting of an acute myocardial infarction. You see a dense cholesterol core with a thin cap over it that ruptures, and when that material gets exposed to the bloodstream, as it is with a lot of maladaptive processes in the body forms a clot, which is not helpful to the heart in terms of receiving blood, and ultimately translates into a heart attack. And you can see here, this is the left anterior descending artery supplying blood flow to the heart, and you can see what happens when there is complete obstruction, absence of blood flow, and subsequently myocardial damage or heart damage. But again, the key is we want to intervene early. We want to intervene medically before an event like this happens. And so how do we figure that out? How do we determine who is at risk? One of the tools that we have are these wonderful calculators that combine a variety of variables: somebody's age, somebody's gender, somebody's cholesterol, somebody's blood pressure, whether they're diabetic, whether they smoke, and we can plug in these variables and actually come up with a numerical risk percentage in terms of what the chances of a heart attack or a vascular event may be. We do this over a 10-year time frame, and we can do it over a lifetime as well. And our threshold to treat, as guided by the American College of Cardiology and the American Heart Association, is 10%. So if your risk of a heart attack, based upon these variables using these calculators, is 10% over the next 10 years, we recommend treatment. If your risk over your lifetime, depending on what your risk factors are related to family history and genetics, is 40%, we recommend treatment, because we know that if we intervene early, if we address circulating high cholesterol at a young age, we can change the natural history of plaque progression. If we're still not sure what we want to do based upon meeting the patient, talking to the patient, looking at the risk calculators, we have these wonderful imaging techniques to try and identify people who are high risk. As I mentioned, when plaque starts to form in the arteries, one of the major components of plaque is calcium, actually. And just like you can do an X-ray of your leg and see bone, you can do an X-ray of the heart and see whether or not calcium is depositing in the arteries. And if you have calcium in the arteries, that's a surrogate. It's a marker of plaque. And a calcium score is essentially an X-ray or a low-dose CAT scan that simply takes an X-ray of the chest and identifies the presence or absence of calcium. If you have a lot of calcium, that means that your risk of heart disease is high, and we would recommend treating your risk and lowering the chances of having an event. But the good news is, if your calcium score is totally normal, irrespective of anything else, there's a lot of prognostic information gleaned from it. A perfect calcium score portends a 0.1% risk of a heart attack over 5 years and a 1% risk over 10 years, which, as you can imagine, can bring a lot of relief to somebody who's concerned about their risk of having a cardiac event. So it's a very powerful tool that offers a lot of important prognostic information. Best used for somebody who we can't decide what we want to do, or if we know what we want to do, we want to put them on cholesterol pills, we'll use it to sort of push the needle a little bit. Sometimes seeing is believing, and when somebody sees the CAT scan and they see the arteries with calcium in it, it really is convincing. So it's a very helpful tool. So let's get beyond prevention and let's talk about what happens when somebody is experiencing a symptom. As Bob had mentioned, common symptoms of coronary artery disease include exertional chest pain, exertional shortness of breath. And when somebody is presenting with the symptom, we have to evaluate that symptom and decide, is this or is this not a coronary manifestation or not? And we use a variety of testing, including stress testing. We put patients on the treadmill, we watch them exercise, we look at their functional capacity, we look at their EKG to see if they're developing concerning changes. We're capable of doing imaging in addition to EKG stress testing, where we inject patients with a radiotracer that attaches to blood cells and then goes to the heart, and we can see where there's deprivation of blood flow or where blood flow is going. And we can also do echocardiograms with stress testing and see with exercise, is the heart contracting the way it should or not? And if it's not contracting, it's a signal of a blockage. So we have these wonderful non-invasive ways to assess symptoms that may or may not be concerning for coronary artery disease with excellent accuracy, sensitivity, and so on and so forth. But in cardiology, we're always pushing the envelope. We're always trying to do better. And in the last 10 to 15 years, we've seen an emerging technology called coronary CTA, whereas the prior imaging studies sort of indirectly looked at the presence or absence of blood flow in specific arteries. Coronary CTA is a non-invasive way to directly visualize the arteries themselves. And a lot of times it's used hand in hand with stress testing to help guide appropriate therapy and whether or not an intervention is appropriate. I'm sure everybody in this room has had a CAT scan at some point in their life. It was a little bit more challenging with the heart because the heart's a beating organ, and so it took us more time to figure out how to get an optimal study, but we're much better at it. It's widely available, it's well tolerated. A great advantage to it is that it actually visualizes the arteries. So let's say you do a coronary CTA on somebody and they don't have a significant blockage. That's great news, but we do see a small amount of plaque. That's powerful. It's important to know, because if I see a small amount of plaque in somebody, I may not say they need an angiogram, a cath, but I may decide, you know what, let's put you on a statin. Let's get the cholesterol under control so that we can nip the problem before it becomes nip the problem early, and that's why it's a very important diagnostic tool. Some limitations, as there is with any type of cardiac testing. Calcium sometimes makes interpretation difficult. If you've had a prior stent, it's not well validated. And if you are allergic to contrast or you have kidney dysfunction, then it makes it a little bit more difficult to pursue these type of studies. I thought this was just a very cool example of the right coronary artery in which there's a significant blockage. I think you can all appreciate that in the mid part of the vessel with an eccentric plaque.
Use your pointer.
Right there. I don't think you need to be a radiologist to see it, but it's impressive, yeah. And of course, then there's the gold standard, which is a coronary angiogram. And this is just an example of the left anterior descending artery being occluded. Dr. Dreisman is going to show a wide variety of cardiac casts, so I'll let him do his thing. So let's talk a little bit about treatment of coronary artery disease. Once you've had an event, or once there's we determine the presence of significant coronary disease, the cornerstone of therapy is antiplatelet drugs. You've heard of things like baby aspirin, Plavix, Brilinta. Those have been well shown to reduce the risk of heart attack, especially in patients who have had prior events. Cholesterol-lowering therapies, which we'll focus the rest of our talk on, is the bedrock of prevention. Beta blockers to reduce heart rate and to relax the heart have also been shown to be critical in protecting overall cardiac health. And in patients who have a chronic chest pain syndrome, we use a lot of anti-anginal therapies, medications that basically help relieve chest pain by opening up and dilating blood vessels or reducing the amount of work the heart has to utilize. Cholesterol, hypertension, tobacco, diet. These are all critical to intervene upon, but as the cardiologist, our focus is going to be on cholesterol. The cornerstone of any treatment for prevention, for secondary prevention, is statin therapy. And these are just sort of the most common examples that we prescribe: Crestor, Lipitor, Zocor, and Livalo, which have been around for a very, very long time. And what they do is they actually block cholesterol synthesis in the liver and upregulate LDL receptor expression on the liver. So you have circulating cholesterol in the body. Statins will essentially allow for the receptors that capture the LDL in the bloodstream to be more prevalent, thereby reducing the amount of cholesterol in the bloodstream and also blocking, as I had mentioned, the formation of cholesterol in the liver. And what's reassuring to know is that statins work. You get somebody on a good dose of Lipitor or Crestor, you are going to lower their LDL by upwards of 30 and 40%, which is wonderful and lends itself to really good outcomes. Oh, LDL is bad cholesterol, sorry, in case you don't know. And HDL is good cholesterol, but the target mainly of statins is to lower LDL. And so what is the data? In patients who we deem intermediate risk or we think have a 5 to 10% chance of having a coronary event over the next 10 years, if you go on a high-potency statin and achieve an LDL goal that satisfies the cardiologist, you are 30% less likely to suffer a heart attack or a stroke. If you're high risk, you're upwards of 40% less likely to suffer a heart attack or stroke. In patients who have already had an event, In some studies, we can reduce the chances of having a secondary event, another event, by upwards of 50%. And in patients who have had an acute coronary syndrome or a heart attack, we can reduce the chances of mortality by 25%. So it's critical that these medications be prescribed to prevent coronary disease, coronary events, and strokes, and of the like. And that's the reason why, if you've seen a cardiologist, you probably have heard them harp on why it's so important to, if you don't tolerate one statin, try another. We're trying to make you live longer and feel better, which I think is a worthy goal. The good news is, if you're in the 9 to 10% of people who just can't tolerate any statin, there are non-statin oral therapies that can be effective, not quite as effective as statins, but can be effective in reducing the chances of heart attack and stroke, including Zetia, which blocks cholesterol absorption in the gut, and Nexletol, which lowers LDL by about 20%. And recently, actually, there was a big cardiology meeting in, I think it was New Orleans last week, and Nexletol was demonstrated to reduce the risk of heart attack and stroke by about 10%. So, like I said, about 9 to 10% of people can't tolerate a statin. Rest assured that there are other options available to you in terms of oral therapies. Injectables have become very popular in the last few years. Things like Repatha and Praluent, which are known as PCSK9 inhibitors, can be dosed every 2 weeks or every 4 weeks, and typically are given to patients who are not at a certain LDL goal, despite maximally tolerated statin and Zetia. But frankly, in the real world, we're also using it for patients who can't even tolerate a statin, and they're incredibly effective, lowering bad cholesterol by upwards of 60% and reducing the risk of a heart attack and stroke by upwards of 25 to 30%. The latest and greatest on the block is a new drug called inclisiran, which is an injectable drug given every 6 months. Pretty incredible, with an associated 50% reduction in cholesterol. We're optimistic that there will be outcomes data with this, reduction of heart attack and reduction in stroke, but nothing has been published yet, so stay tuned. And to summarize, these are my really adorable daughters, and they wanted me to tell you that LDL lowering decreases the risk of cardiac death, heart attack and stroke, and recurrent ischemic events. With treatment, the magnitude and reduction in risk is related to baseline risk. So basically, the lower we get you, the better you'll do. Thank you.
Thank you. Thank you, Ari. Again, the basic take-home is cholesterol bad, low cholesterol good. That's really what it amounts to. And the cholesterol hypothesis, which has basically been getting cholesterol low will decrease coronary disease and cardiac death, has been shown in multiple studies. I know there's a lot of lay people who have concerns about statins, for instance, which I think is one of the wonder drugs of the clinical years that I practiced. These are amazing medications. One of the reasons we wanted to have this lecture is just to encourage people to not only diagnose early coronary disease, but treat it aggressively and take it very seriously. Now I'd like to introduce Dr. Dreisman. Dr. Pollack talked about the medical therapy of coronary disease, but as you know, there's angioplasties, there's interventional atherectomies, there's coronary artery bypass, and that's where Dr. Dreisman makes his living and does a beautiful job at it. So Dr. Dreisman, if you'd please speak.
Continue on a personal note, it's really a joy being here. When I came here in 1982, Bob was the premier internist. I can remember our children, Emily and Mikey, playing together in preschool. So we go way back. And to watch Ari, who's sort of another one of my sort of work sons, do a phenomenal presentation like that. We sort of built a practice. We started as 2 cardiologists, and we built a practice by saying we always want to hire people better than us. And Ari's an example of that. And now there are 23 of us in cardiology covering all the different fields. It's been, really wonderful to see the evolution of cardiology. When I started, you sort of did everything, and all of a sudden it broke up into different fields of cardiology. You had the general cardiologists, you had the lipid people, you had the plumbers, the interventionalists. We now have electricians or electrophysiologists, and cardiology's exploded, and I often say it's better to be lucky than smart. I was lucky to sort of pick the right field and watch the transition in the field, and when I started, angioplasty didn't exist. we were just entering the field of bypass surgery, and to see how we've evolved from balloons to stents, to balloon angioplasty, to stents, to medicated stents, to cutting devices, to scrapers, different types of open heart surgery. It's really been a wonderful ride. So on that note, what I'd like to do is basically give you a little tour of some pictures. And let's see if I can do this without too much trouble. Actually, I need my glasses. Excuse me.
He's been practicing a long time.
Really? Isn't that the truth, Bob? Both of us. What I wanted to start off with was a normal coronary angiogram. Again, we're plumbers. And as Ari pointed out and Bob pointed out, basically the coronary arteries, just think of them as pipes. And when the pipes get blocked up, how do you unblock them? We have ways to unblock it with plumbing, and we have medications. This, is it playing? Is a normal coronary angiogram. And let me use my pointer. This is where we put a catheter into the artery of the heart. And let's see if it keeps playing here. This is the catheter in the coronary. This is the left circumflex coronary artery. This is the left anterior descending. We inject dye, and we see where the blockages exist. And I want to keep on, just show you a bit of a normal coronary angiogram. The next one, and again, circumflex coronary catheter, left main, left anterior descending, circumflex coronary artery. And what we do is we basically put our catheters in the heart, we thread it down. I think it may be illustrative to show you how we do this from a little video. Let me start with a video here. And then we're going to give you a tour of different things. So this is a video how we do a coronary angiogram and a coronary angioplasty. As you saw, this is the heart. These are the coronary arteries. The artery on the back side of the heart, the right coronary artery, left anterior descending, that we like to call the widowmaker, and you can imagine why. And what we do is we talked about the blockages in the coronary arteries, but we have to visualize where the blockages are. We do that by putting a catheter into the arteries of the heart. Initially, and as many of you know, we did all of our coronary angiograms from the groin. We have now moved to the radial artery, which is much simpler on patients. We're able to put a catheter and a sheath into the radial artery, advance what we call a guide wire, and in this manner, be able to reach the arteries, not the veins of the heart, by advancing a wire, as you'll see. This comes in through the radial artery, through the brachial artery, through the arteries of the arm, into the main aorta. Over this will pass what we call a guide catheter. And you'll see that in a second. Here's our bigger catheter that will then be placed into the aorta and placed into the arteries of the heart. From there, we can inject dye and see what the arteries look like. This catheter, I believe, we're going to put into the left anterior descending, inject dye, and you'll see what an artery looks like, and you'll see what a blockage looks like. When we identify a blockage, and it's not always so focal, we then can, when we can approach it, we can fix it. Again, this is the plumbing that we talk about. You saw these pictures back from Bob and Ari, but basically we'll advance a small wire through there. Over the wire, we'll advance a balloon catheter. We will then open up the vessel, if you will. Now, in the old days, back in 82, 83, 84, when we did the first one in the state, oftentimes these vessels would collapse. And that was problematic. You'd push a vessel, it would open or would collapse. We have evolved to the point where instead of just having a balloon, we now have stents that mount on the balloon, and the stents are placed within the coronary artery and in the area that we've previously pushed. In fact, the stents now are not simple metal. They're drug-eluting stents. We use these stents as a way of delivering medications to the atherosclerotic plaque and prevent atherosclerosis and prevent what we call neoproliferation. And you'll see a stent being deployed, opening up the vessel, buttressing the vessel, providing medications to the vessel, and restoring blood flow. And this is basically what the schematic of what we do. Let me go back and show you some examples. First, people like to talk about bypass surgery, and bypass surgery still exists. When we can't fix a vessel with medications, which is certainly the first thing we do, try to use medical therapy, and it's the blockages are too extensive or diffuse or in a region that we can't readily approach safely, that's when we think about bypass surgery. And let me show you an example of that. Now, this is an interesting case. This is a case of bypass surgery where a previous valve is in place. So this is a porcine aortic valve in the aortic position and a catheter in the left main coronary artery. I'm sorry, these are not playing quite as well as I'd like. Again, an aortic valve, injection in the coronary artery. This is the right coronary artery. You can sort of see a stent. It's totally blocked, and the stent is totally occluded. And if you take a look at the next picture, this is a bypass graft where we put basically a vein, typically from the leg, hook it up to the aorta, and it's placed into the coronary artery and bypassed. And I'm wondering if I can go back. How do I play this again? Let's see. So yes, you'll see the catheter going into a bypass, injecting dye, and this is the distal vessel. And we can see this on multiple views. Again, a bypass to the right coronary artery. So there are different ways of getting around blockages, if you will. Now let me show you a few others. I want to show you, let me scroll down. We're making your cardiologists here whether you want to be or not. Again, here is a catheter in a right coronary artery, a native right coronary artery, where we're injecting dye, showing that it's patent and open. But if you go to, but there is a problem. The problem is in the circumflex coronary artery, which I'm going to try to scan over to. Let me keep playing here. I'm sorry, I'm having just a bit. Hold on one second. Okay. I'm hoping you can appreciate that right over here, I think this shows it best. Can you appreciate the blockage over here in the circumflex coronary artery? And I'll try to play it back a few times. So here we have an obstruction, an atherosclerotic plaque there. What's the next thing we do? We then proceed to some minor technical problems here. My apologies. Again, the blockage, and we're going to, now you'll see that through the blockage, we placed a guide wire. And I'll try to keep playing that back a few times. Now, here's our guide wire through the blockage. And we're going to then proceed to get a balloon through there, which I'd love to show you here. You'll see the balloon catheter inflated, opening up the blockage, followed by a stent. This is the stent deployed. Positioning it just properly. And here you'll see that the vessel is open. Where we previously had a blockage, the vessel is now open. So this is basically what we do. What we do is we put a catheter in, it's all sequential, if you will. You put a catheter into an arm, you then pass it backwards to the artery surrounding the heart, inject dye, find out where the blockages are. Once you determine the extent of the blockages, you make a determination how the best way to revascularize. And again, there are multiple different modalities. There's the ability to do it with balloons, the ability to do it with stents, the ability to do it with bypass surgery, and probably most importantly, the ability nowadays increasingly to do it with medications. One of the things we wanted to discuss is it doesn't always have to be a mechanical fix. It really can be a pharmacologic fix. And I know Bob, Ari, and I were talking about some recent trials, one of them a very important one called the ischemia trial, which talks about how really, in terms of prolonging life, you do as well now with medications, oftentimes with the mechanical revascularization. As an interventionalist, as someone who's done literally probably 10,000 angiograms and angioplasties, you start to realize that our new medical technologies are oftentimes every bit as effective as the more pleasing and visual mechanical fix. Ari, any thoughts on that? Would you like to mention the ischemia trial a bit?
Yeah, it was basically a study that looked at patients with critical blockages. They excluded the highest risk blockages, but included included a lot of patients who had significant disease, and essentially randomized them to medical therapy with cholesterol pills, baby aspirin, beta blockers like we discussed versus stents. And they basically showed that in terms of reducing the risk of heart attack and reducing the risk of cardiac mortality, there was no difference. There was no difference. And I think the point is that when you are thinking about coronary stents and really where they are best utilized is for patients who are unstable. So patients who are in the midst of a heart attack or who are having an accelerating chest pain syndrome. In an unstable patient, in an unstable lesion, stents have been shown clearly to reduce the risk of heart attack, reduce the risk of cardiovascular mortality. But in somebody with a stable syndrome, medical therapy in terms of protection of heart attack and mortality has been shown to be equivalent. One other thing we should mention is that in patients who do have angina, who fail medical therapy and continue to have chest pain that impacts their quality of life in a meaningful way, stents are wonderful in terms of reducing the presence of chest pain, and it's important to know that angina is uncomfortable. Angina is debilitating. I'm sure walking around knowing you're having chest pain and it's your heart is not a comfortable thing to have to deal with. So stents play an important role in patients who fail medical therapy who continue to have chest pain.
Both medically and psychologically. I mean, different people do better with different types of modalities. But I think it's important to understand we have so many ways cardiology has evolved. We're talking today about plumbing, about atherosclerotic coronary disease, about blockages in the coronary arteries. We're going to, in future discussions, talk about arrhythmias. We have the ability now to intervene percutaneously from the groin with new valves, both in the aortic position and the mitral position. There's been a tremendous evolution since the late 70s, early 80s. And, you know, it's just been a wonderful journey, and the journey has been particularly exciting because we've seen how we've changed morbidity and mortality in cardiology in general in this community, and it's been an exciting run. But let's take some questions now.
Well, thank you, Mitch, very much. I don't think anyone can really appreciate it. I mean, certainly in the years that I practiced, when I started practice, virtually none of this existed. We had nitroglycerin, early beta blockers. We didn't have angiograms, angioplasties, atherectomies, stents. Bypass was relatively in its infancy. That's not because I'm that old. That's because this has really been going at breakneck speed, and it's really remarkable, and people are showing absolute benefits, living longer. I think the incidence of cardiac death is actually dropping in this country. Something really remarkable in our lifetime. I did want to open up the forum to any questions from the audience, and I believe where that woman is standing is a microphone. I hope we have some questions from the audience. Otherwise, you're just going to have to listen to the questions that I have posed for the panel. So please take a walk over there and ask any question you might have. You've got two really great cardiologists here. Take advantage of them while you have them.
Thank you. Thank you very much. It was a really excellent presentation. I have a couple of questions. Hopefully they're all related. Less than a month ago, a good friend of ours in his 60s, really good shape, very athletic, underweight, ate well, non-smoker. I think he's, checked out fine with his physicians and his, stress tests and stuff. He was snowshoeing in the very cold weather, and he literally dropped and coded. And fortunately, there were enough people around him that they got EMTs there very quickly, and they were able to resuscitate him. When they got him to the hospital, and they got him to the cath lab, the plan was to stent him, but when they got in there, they discovered that it was calcified, and it was hard as rock, and so they had to do bypass. So it got all of us thinking in this social circle, men and women, all of our friends, thinking, well, if he kind of checked out normally and he was in good health and very active, and there was no sign or symptoms that this just happened to him and he was calcified already, and there's obviously a lot of plaque that had built up. If that could happen to him, couldn't it happen to one of us? And what's happening in the clinical setting, I mean, when you go for your annual visits and whatnot, to maybe request a calcium score or a CT scan, cardiac scan, is this being sort of considered as part of your normal workup and what's happening with insurance? And is it something you should ask for, or is it something you have to wait for your physician to prescribe?
Ari, why don't you take that?
I'm very sorry to hear about your friend, and I hope he's doing well.
He's doing great.
Right, I'm glad to hear. Obviously, without knowing the details, it's hard to, say whether or not he got optimal care leading up to it or standard of care, or it's just hard to know. I could tell you in my own personal practice, I have a very low threshold in somebody who I'm concerned about or worried about, who, despite feeling fine, strikes me as somebody who I think might be at increased risk. So you don't have to ask me to order a calcium score. It's part of, in my opinion, almost a routine evaluation. In terms of, has the insurance world caught up to it? So interestingly enough, no insurance company will pay for a calcium score. But the good news is a lot of the vendors who offer the technology locally offer it at a reasonable price. I think the cheapest calcium score locally to patients is $125. Other places in the state offer it as low as $99, depending on where you're going. But in that particular instance, sometimes there are clues that perhaps get overlooked. And I think, if you're interested in being proactive and adopting an aggressive preventative strategy, seeing, a wonderful internist or cardiologist is a good start. And I could promise you that for those of us who are truly current and on top of the technologies available, things like calcium scores are becoming much more routine. Is that the place to start, or is a cardiac scan and a calcium score the same test? It's different tests. So a CAT scan looks at blood flow, typically reserved for patients with a symptom. I think the most important thing is get in the office, meet the cardiologist. I mean, there are some instances where I see a patient and I say, the calcium score is not going to be helpful. I know they need to be treated. And we start, irrespective of a calcium score or not. There are other patients who we use it as a tiebreaker, and like I said, there are other patients who I use it to convince to do the right thing. So I think the most important thing is get in, see somebody, and if you're not getting what you want out of the visit, pose the questions that are on your mind.
Thank you.
And just a comment or two. Number one, it's interesting, it happened in cold weather. You're far better at resuscitation in cold weather because effectively the patient's heart was put on lower metabolism. And in fact, when we have patients who have to be resuscitated, we'll oftentimes put them in a cold environment, in a hospital setting. Talking about calcium, 2 points. Calcium doesn't represent the new plaque. Calcium is not the plaque that exploded, as Dr. Pollack, as Ari showed. Those are the older plaques. Those are the plaques that have scarred down, they've healed, they have some limitation of blood flow, but those are not the plaques that typically cause the heart attack, if you will. And the other comment on calcium is we often say in the cath lab, calcium is the bane of the existence of an interventional cardiologist, because the calcium within the plaque sort of grabs your stents, makes it very hard to place a stent. But again, we have all new technologies now where we literally have rotobladers and ultrasound catheters that can break up the calcium, that can pulverize the calcium and allow us to revascularize. I suspect the patient had bypass surgery rather than intervention for a multitude of techniques, a multitude of reasons. The calcium makes it harder to revascularize, certainly, probably suggests diffuse and extensive disease, and oftentimes you do better with bypass surgery, and possibly the location of the blockages as well.
Just one thing, as an internist, I happen to have low threshold for getting calcium scores too, but I must say I don't believe any formal guideline that tells physicians to get calcium scores, if I'm not mistaken, nor is there a definitive study that shows that it prolongs life.
That's changed actually. Now there are guidelines in patients who are intermediate risk who you're using to help decide to treat or not to treat. And somebody who's high risk.
But I'm talking about a healthy young woman, normal cholesterol, non-smoker, and wants a calcium score because she came here.
Yeah, so in that instance, I would agree that the guidelines would not necessarily suggest it, and then you have a conversation with the patient and discuss the risks, benefits, why to do it, why not to do it. I mean, and ultimately make a shared decision. You know, that story is not unique, unfortunately, and my sense is, again, not knowing the details, if that they met somebody who was really interested in prevention 10 years earlier, that the natural history of what happened to that unfortunate person who thankfully is doing well might have been different. I think if you put that person on a cholesterol-lowering therapy 10, 15 years ago, I think he would have been okay.
And one other thing which isn't quite clear is if you do get a calcium score and it's good, when do you get the next calcium score? 3 years, 5 years? Yeah. Just these are vague kind of ideas.
Yeah, it's a good question. So the calcium scores are very incredibly accurate at prognosticating. And so if what a calcium score of 0 tells you is that your risk over 10 years is about 1%. So we kind of use that as a benchmark to say, listen, 10 years, you should be okay, except the 1% risk, and then after that, it's reasonable to repeat it. And somebody who I'm a little bit nervous about, who I think might be at risk of an accelerated process, maybe I would repeat it at the earliest 5 years, but before that is unnecessary. I should also mention that diabetics, in general, we don't do calcium scores in because, as a general rule, we treat any diabetic as having coronary disease anyways, so it's not necessarily a worthwhile test in that specific patient population.
And they do have high calcium scores, just being diabetics. And one other point that should be noted is once your calcium score is elevated and you're placed on a statin, you can have regression of new plaque, but the calcified plaques are there and they're only going to get harder. The calcium score will go up as prognosis improves. So serial calcium scores, people come in and say, gee, my calcium score is 200. I've knocked my cholesterol way down. Let's get another one. Let's see if it's better. It won't be. The calcium score will be worse, but you'll do much better and you'll live longer.
Understand that.
We have another question?
Yeah, but I don't understand what he just said. Why is the calcium score going to go up?
Because calcium represents healing of a scar. And basically you have a plaque that fibroses and becomes calcified. The beauty of a statin is it stabilizes the plaque. It builds up it actually stabilizes the scar. It becomes more calcified. It can't rupture, as Dr. Pollack showed you. So you'll have much less chance of having a heart attack from that particular area, but the scar the fibrotic lesion will calcify.
So when you speak of calcium, you're not speaking of plaque, two different things?
Let me try.
That's confusing.
So when plaques in the heart can be either calcified or non-calcified. And Patients who have a lot of calcified plaque also have a lot of non-calcified plaque. It's actually the non-calcified plaques that tend to become more unstable with time. And when you calcify those plaques, which statins do, you are actually stabilizing those non-calcified plaques that are problematic.
I got it.
And so, to Dr. Dreisman's point, while your calcium score may go up on the statin, your chances of a heart attack are going way down.
Because you're stabilizing the
You're
plaque.
stabilizing the non-calcified plaques that you can't see.
Think of it as a buttress, a natural stent, if you.
Yeah, thank you.
One thing you might ask is why then are we just looking at the calcium? And the reason is because that's what the scan sees. It can't see the cholesterol, the little streaking cholesterol. It sees the cholesterol that has subsequently been calcified. It's part of the limitation of the test.
Yeah.
My initial question was actually,
Question for you. Is it a bad idea to exercise in extremely cold weather anyway? You're just asking for a heart attack. I mean, that's...
Can you go to the microphone, please, just to say what you're saying,
Maybe we should
please?
let her talk.
I'll
Yeah.
let her talk because,
Yeah.
I mean, I have a big mouth anyway. I don't really need a microphone. But it's true.
I mean, there's a line.
okay. My first question was actually related, and this whole discussion, I was really going to say I didn't understand why almost everybody doesn't get one of those, because my first was from a friend who was kind of really good, good cholesterol, a little bit high total, sort of borderline-ish, I guess, and did go have a scan, and her doctor said, well, there you have it. It's there. So to me, that meant, why don't you just go get the scan, because the scores were not really probative. The scan was what the doctor said. Now we know it's there. We don't have to wonder whether or not you're borderline, not borderline. So I guess you've answered that whole question, but it seems to me they're a good idea. Next question is, this is just coincidental that you're here because some friends and I have been talking about some of these things. And one thing I looked at is there was this idea of rather than regular lipid tests, sometimes it's better to get a vertical auto profile. Is that something that, because it goes into more detail and
Yes,
it'll tell
so
you a little bit more?
There are a lot of different advanced lipid tests that are out there, and oftentimes, I'd say oftentimes, there are a handful of times where those can be helpful. For example, in a young person who has a family history of cardiovascular disease, but is probably too young to start calcifying plaques, and they want to understand what is their chance of running into trouble over the next 20, 30, 40 years. You know, you're not going to get a calcium score in that person, but what you might do is get an advanced lipid profile to try and understand their lifetime risk a little bit better. So that's when I choose to use that type of testing.
Yeah, I'm going to go to the end of the line so other people can go. I had one or two more.
Hi. I think you've basically answered my question, but I have another question. So my basic situation is that, Bob, as you know, I'm one of those 3% people. You know, I eat well my whole life. I exercise every day. I've never smoked a cigarette in my whole life. And I recently had a calcium score test, and my calcium came back as 294. So that was quite high. I mean, my new doctor was expecting it to be 0. So then she put me on a statin, Dr. Casale. I think she works in your practice. She's great. She put me on a statin, 10 milligrams, so I've been taking that. So my original question was, if my cholesterol's low, if all of my numbers are good, which they have been all these years, what does a statin do? I think you answered that. But now my question is, because I was thinking if it lowers your cholesterol, mine's already low, so what's it really doing? But now my corollary, my second question is there anything else that I can do for my heart health that I'm not doing right now?
Agreed, Dr. Casale is wonderful. And, genetics matter too here. Let's not forget that. And so, it sounds like to some extent a lot of this was the hand you were dealt. I don't know what your cholesterol numbers were, but whatever your cholesterol was still allowing plaque to deposit in your arteries. Mm-hmm. And so we moved the needle, and we're more aggressive in people like you who, despite a good cholesterol, have an abnormal calcium score. So instead of aiming for good, instead of aiming for great, we aim for perfect. And that will still translate into a benefit for you. It will lower your risk of heart attack. attack, it will lower your risk of stroke. Above and beyond lipid lowering, statins also have an anti-inflammatory effect on the blood vessels that we think also contributes to health and well-being of the cardiac patient as well.
Thank you. I wanted to ask you guys, hearing you talk about your beginnings, Dr. Dreisman, and what you experienced starting in this field, how do you see technology impacting over the next 10 years with things like nanotechnology, AI? How do you see your treatment changing?
Great question. I mean, I think it's fair to say you'll move away from the mechanical approach, the simplistic plumbing approach, to the new technologies and the new medical technologies. Would you like to take it from there, Ari?
Yeah, I mean, I think, again, it's all about trying to identify the people who are going to run into trouble at the earliest possible point. And I think that's where all of medicine is going, right? You know, we want to get you before there's a problem. And if we do, and we get you on medicines, we're going to keep you out of trouble. So that's where I think all of this is going, trying to identify the high-risk person as early as possible.
But how about the new CRISPR technologies, the things we're talking about in terms of new therapeutic modalities? I think it's...
In terms of valves?
In terms of valves, but in terms of even coronary artery disease and lipid. I mean, we're seeing a tremendous revolution.
Yeah, I mean, I think with respect to coronary disease, it's just going to move more and more towards medical therapy. I really do. And in terms of valves, you know, there's going to be another talk here, and if you want me to come back.
That's for another day, but you can come back and hear about valves.
Yeah, I mean, we are getting so good at engineering small tools to get to the heart to improve the problem, you know, and that's going to continue. I mean, we're so sophisticated at treating aortic valve disease, mitral valve disease, that's just going to continue.
What Ari's saying very nicely is my techniques, I'm going to be a dinosaur, and we're moving to genomic changes, and you're going to see tremendous evolution in the next 10 years.
And I don't know if artificial intelligence is going to make a big change, but certainly molecular technologies, development of drugs. I mean, the drugs that Ari commented on, inclisiran, these PCSK9 inhibitors, which are just remarkable drugs, but they're all based on incredible molecular science that has been developed. And then they come up with the mechanism that the disease develops, and then they make a blocker, an inhibitor of that particular molecule. That's really done through very high technology, molecular science, and probably the equivalent of artificial intelligence. I don't see nanotechnology actually making a big impact on.
Yeah, I think you're right. You know, we are, at some point we're going to get to targeting the DNA and RNA and shutting down the process from the get-go. And in certain disease entities in cardiology, like amyloid, which maybe you've heard of, they have medical interventions that are looking at that already. So it's going to, I mean, it's just going to get better and better.
I have to make this quick because it's getting past my bedtime. Real quick here, you guys never touched on the effect of food and what foods are really good for you. I know since corn syrup went into effect so heavily in 1960 that the heart attack rate has gone through the roof here in the United States. And that's when Cuba was cut out in 1960 for sugar cane. But I think food has such a big impact on coronary artery disease. And if you guys have a pamphlet to show what foods are good to eat and exercise, I mean, when there was a farm community in the United States up to 1920, the effect of heart disease was almost non-existent. So when our farm community is gone, you see coronary artery disease. You see petrochemicals being tested on all these people. But I think food is one of the most major impacts to reverse coronary artery disease. Thank you very much. Thank you very much. Thank you.
Thanks for that question, but
yeah, agreed.
I agree.
No argument.
Are there any other questions? I have a few myself, but.
Thank you, doctors. So as part of the mechanical fix, stents are being used very generally in these days. A dumb question it may be, how long the stents last in that particular place of the artery? Do you need to revisit the same spot for replacing the stent you already placed, or you die with that?
I'm going to answer with a little bit of our medical humor. And we have very little humor in medicine. But we often like to say in the cath lab that unlike love, stents are forever. And there's some degree of truth in that. The stent that went in that didn't have an early thrombosis, that didn't have a scar form, and that's the vast majority, that particular stent will stay open virtually forever. You don't see atherosclerosis typically within the stent. What becomes so important after you have a stent put in is the risk factor modification, the changing of the biochemistry that Dr. Pollack does, because you're worried not about the stented region, you're worried about the other areas within the coronary artery, and not just the coronary artery. Remember, atherosclerosis is a diffuse process. What goes on in the heart goes on in the carotid, goes on in the arteries in the brain. In peripheral vascular disease, we have the ability to put stents in legs, in aortas, certainly now stents and other mechanical devices within the arteries of the brain and the carotid arteries. But the stent itself is not the problem. That stent will not be problematic. It's the process, and that's why it becomes so important to reduce risk factors after you place that stent.
Thank you.
Could we have our next person asking questions? We want to make it through this line. Who knew you guys would be this popular?
Yeah, we'll get to that question. I just want one thing to be addressed briefly because it's kind of been in the news a lot. It's a very common question we get, which is the question about using aspirin. Aspirin has been really very controversial. You may have heard of new guidelines. It kind of almost boggles the mind that things have changed so much in the last 3 years since 3 studies. But first, I just was going to ask either of the cardiologists first to distinguish primary prevention with aspirin from secondary prevention, and then maybe you could review the guidelines.
Yeah, so when we see a patient, we think about them as either as either they had an event or they haven't had an event. So in somebody who has never had an event, a heart attack, a stroke, carotid disease or peripheral arterial disease, then when we approach that patient in terms of prevention, we think of them as a primary prevention patient. They've never had an event. We want to keep them from having an event. And then there's the secondary prevention patients, those who have had a heart attack, who have had a stroke, or who have had some type of disease in their peripheral arteries that has manifested in a clinically meaningful way. So it is very clear in the secondary prevention patient, somebody who has run into trouble already, that antiplatelet therapy, either aspirin or some of the newer agents, there's a net benefit to continuing that drug in those patients at the expense of the bleeding risk ensued by taking that drug. That those patients have demonstrated themselves as being high enough risk for recurrence of an event that we continue the antiplatelet drug like aspirin. But most recently in the primary prevention population, those who have never had an event, even if they're high risk, high blood pressure, high cholesterol, diabetes, even if they haven't run into trouble, what we've learned is that if we're aggressive with blood pressure, if we're aggressive with cholesterol, if we're aggressive with their diabetes, that the net benefit of adding aspirin is not there, that the bleeding risk of aspirin outweighs the ischemic protection you're going to get by going on it. And that bleeding risk increases as you get older. And so in my practice, as a general rule, if you haven't had an event, you're not on aspirin. If you've had an event, you're on an antiplatelet drug.
That's somewhat age dependent as well, because over age 60, they do not recommend initiating aspirin for any primary prevention in anyone, which I sometimes would bend the rules if they're very high risk, but anyone over 60. Between 40 and 59, you can do one of those calculations that Dr. Pollack showed, and if their risk is over 10% for 10 years, it's a discussion between the patient and the doctor whether they'd like to consider a baby aspirin. Baby aspirin really seems like a very minimal thing. We don't think of even as a medicine, but in reality, there is an associated bleeding risk. It goes up with age. So after 60, if you've never had a major cardiac or a cerebrovascular event, taking an aspirin actually is either doesn't make any benefit, or in one study was actually a negative benefit. Very surprising, very counterintuitive from everything we thought about 30 years ago, 20 years ago, 10 years ago, until 4 years ago. So it's really a radical change in the paradigm.
An interesting subset just came out from the American College meetings that Ari was talking about in New Orleans, showing that even if it's primary prevention, you've never had an event, but your calcium score is greater than 100, you may get a benefit from aspirin. So there are subsets, and it's
Some
part of.
people would say those people have coronary disease, so maybe it's not primary, it's secondary treatment. That's right.
But I'll still say that even in the highest risk population, diabetics, there was not a demonstrated net benefit overall. There are small sub-studies that have demonstrated smaller benefits, but in the biggest primary prevention study conducted in the highest risk patients, I think that it was very clear that the bleeding risk attached to aspirin is probably not worth it in most patients who have never had an event.
I'm sorry, I didn't mean to interrupt you.
No, that's okay. Quickly, the associated risk or the side effects of statins, can you talk a little bit about that? Is there associated risk of dementia?
So, never proven. There's a handful of anecdotes out there that have become very widely publicized, but there's never been any clear mechanism elucidated that makes any sense, and that beyond anecdotes, there really isn't much more to say other than that. The other thing that I'll say is that there is clearly a demonstrable benefit in terms of reducing the risk of stroke, and probably the number one cause of dementia as people get older is vascular dementia. Mm-hmm. So I still would say that the net benefit, if your goal is to, mitigate your risk of having dementia as you get older, is to get on a statin.
Statin and dementia was a kind of a thing that came out in the 90s and in the 2000s. Really, I think over the years has really been disproven. There is one study that shows a lower incidence of dementia because the most common cause of dementia is Alzheimer's. The second most common cause is a term called vascular dementia. And actually statins can lower the risk of stroke and vascular dementia. So in the long term, actually it's probably a positive in terms of dementia. It does have other side effects like muscle aches, I'm sure you've heard of, occasional, very rarely liver problems, a slight increased incidence of diabetes, but the overall benefits that Dr. Pollack showed are amazing in terms of, you're talking 10, 20, 30% benefits in terms of stroke and heart disease.
There was an interesting study done, and sometimes I'm reluctant to bring it up because, I do believe some people can't tolerate them. I do. About 9% of patients who go on a statin ultimately have to stop. But this I thought was interesting and elegantly done by the American Heart Association. So they basically randomized several hundred patients to a statin and to a placebo pill, a wafer. And all they said was, report back if you don't feel good. Guess what the difference was in terms of incidence of side effects with the placebo pill and the statin?
Equal.
Equal.
Yeah.
And it becomes a self-fulfilling prophecy in a way, So it's just interesting, And I mean, there's enough out there where people have the same complaint that it's probably real, but sometimes if you wish it hard enough, it happens,
And the corollary to that, take a look, go back to the internet tonight. Take a look at the Samson trial, a trial performed in Britain. They took 100 individuals, put them on a statin, put them on placebo, or let them know they were taking no pill. So a third were taking a statin, a third were taking placebo, and a third were taking nothing, and knew they were taking nothing. But the placebo and statin patients didn't know which one they were taking. Statins had about 9% incidence of muscle ache. Placebo or nocebo had an 8% incidence of muscle ache, and no pill reported a 1% incidence of myalgias. And that's a fascinating trial, and I think it's useful.
But I do believe statins cause muscle aches in certain patients. I had one other question for Mitch, which is we've talked about medications, which are really, I think, in the future, the way we're going to be doing this, interventional cardiology catheters. Is there a role for coronary bypass still?
Still? Oh, of course. I mean,
that was a loaded question.
Yeah, no, thank you. Certainly, if you take a look, if you asked me this question 10 years ago, I would have said a third medical therapy, a third interventional therapy, and a third bypass surgery to deal with unstable angina, unstable symptoms. Now, if you ask the same question, we honestly say with angina, not necessarily myocardial infarction, probably 60 to 70% medical therapy, probably 20% interventional, and there still is clearly a role of bypass surgery. There's diffuse disease that we can't readily revascularize with stents because it would require 6, 8, 10 stents. There are certain locations within the coronary artery, specifically bifurcation of left main, the major vessel where the other vessels come out of.
Bifurcation means a split. The left main is the biggest artery in the heart. the left anterior descending and circumflex come off it. So if you have a blockage in the left main, you call it a day.
And that's evolving. You know, 10 years ago, we never went into a left main. It was felt you couldn't put a stent in the left main because it could close and the person would die immediately on the table. Now, a number of studies have shown that doing stenting of a left main is very doable, but there are certain anatomical situations where it's right at the bifurcation, it's not well suited. And we talked about calcification. And if there's extensive calcification, again, not well suited to intervention and needs bypass surgery. So bypass surgery clearly has a role, but it's down probably 80% from its heyday in the 80s and 90s.
Not a good time to be a cardiac surgeon.
So I think we're done with our audience questions, but it seems like we've had a really good, attentive audience. You all enjoy this? Yeah, I did. I was taking copious notes for my 3 doctors here. But I'd like to thank Bob Altbaum as our host and internist, who will be here every time. Mitch Dreisman, brilliant cardiologist, if I do say so myself, and Ari Pollack. That's great. Thank you so much for coming. So part 2 of this series on cardiology focused on atrial fibrillation, also known as AFib, which I always thought was a small lie, is going to be, I know it's a terrible joke, isn't it? Monday, April 17th, and a date for our final evening on valvular heart disease will be announced very soon. But I'm delighted actually at the turnout, and I hope that you'll tell your friends, and we'll build upon this. And if you really like this series, I'm hoping that Bob will stick with us and we can do all the ologies. All right, thanks so much for coming.
Thank you very much.